Good evening. Let me just start loading this presentation so we can start talking about what I'm doing here today. So my name is José Maria Costa and I'm the lead for Pediatric Allergy Services at UHCW. I would like to thank the organizers of this course for inviting me to do this presentation, and I would also like to thank my two lovely nurses that are specialists in respiratory problems, Hayley James and Kate Weller, for helping me with the asthma point of view of this presentation. So, going very quickly into the conflict of interests, I received a fee from Thermo Fisher to do this lecture. I'm sponsored by Abbott to attend several events, and I work privately at Nuffield Health. So, why am I here today? I'm going to discuss with you rhinitis, both being non-allergic and allergic, and the effect mainly of allergic rhinitis into asthma and mainly allergic asthma. So let's start by definitions first. So for you to have a diagnosis of rhinitis, there needs to be a clear discharge, a blocked nose or congestion, sneezing and itching. And two or more of these symptoms need to happen at least for 1 hour a day. So let's start with non-allergic rhinitis and for you to have a fairly brief idea of what it is about. So, as with allergic rhinitis, this is a condition that affects the nasal mucosa and eventually the eyes and sometimes also the throat. This leads to inflammation that leads then to the symptoms that you normally see with the discharge, itching, sneezing and blocked nose, and for the eyes with red, watery, itchy and swollen eyes. So what we need to know independently of being allergic or non-allergic. So the non-allergic one is diagnosed by exclusion. For us to get to this stage, we have done already several skin prick tests, eventually specific IgEs, and all of them have been negative. So we know it is not a type 1 allergic condition in nature, and we need to look a little bit further to see what else can be causing it. It's also more common to see it from about 20 years of age, though sometimes earlier than this we can also see it. But rhinitis in general, being it allergic or non-allergic, affects roughly 25% of the general population. And what is also important to know is that despite the causes being different and unless a cause is not found, the treatment is often the same. So what are the main causes of non-allergic rhinitis? There's a big list, so I'm not going to go through all of them, but for you to have a general idea, it can be roughly divided in 14 subgroups. Eosinophilic, autonomic, drugs, hormonal, food, atrophic, primary mucus defect, primary ciliary dyskinesia, systemic or inflammatory, immunodeficiency, malignancy, granulomatous diseases, structural abnormalities, and idiopathic. As you can see on the right-hand side of this slide, you can see that the triggers for it are so immense that you really need to look quite further into it, and sometimes you need to involve several teams for you to know or can make a proper diagnosis and then decide what treatment needs to be done apart from the normal nasal sprays and so on. So, moving swiftly into allergic rhinitis, which I think it is the most important thing that we need to look into and to be able to properly not only diagnose but manage. So, allergic rhinitis, also known commonly as hay fever or pollen allergy, though as we know, it's not just pollen that causes allergic rhinitis. But the reason why it is called hay fever and allergic rhinitis, or pollen allergy, has to do with the initial findings that led to the term that we use nowadays. So, coming back to history-wise, how was this found originally? So, this was done by Dr. Bostock in 1819, which was called it a summer catarrh. It was summer catarrh because it was a normal condition that was affecting most people, normally around summertime, and normally it was also around the time that hay fever used to be more common. So because of that, the term hay fever was also coined. So though the name hay is there, in reality we're talking, as I said previously, not just about pollen allergy, but any airborne allergy creating a nasal symptoms and associated symptoms. So just for you to have an idea about what rhinitis means, rhino comes from the Greek nose, and that's why you also have another important name associated with it, which is rhinoceros, for instance. And itis, as all of you know, is also coming from the Greek and means inflammation. So why is it so important to talk about allergic rhinitis more than non-allergic rhinitis? So, first of all, it affects the quality of life. Both of them will do. But along with asthma and atopic eczema, it affects over 20% of the general population. It is the most common and most underdiagnosed and mistreated of all the diseases. And it also leads for something extremely important, which is the risk of developing asthma. And this is due to one thing called the one airway hypothesis that was starting to be thoroughly investigated by Gladys Scadding quite many years ago. But also, we cannot forget about the overall cost, not only in terms of money-wise for the health services, but the personal cost because of how it affects the life. Later on, I'll show you a brief slide about how much does it cost on a statistic that was done quite a few years ago, and probably get to have a better idea of how it is important for us to start tackling this as soon as possible, as soon as and make a diagnosis as early as convenient. So what does lead into allergic rhinitis? So first of all, it is about the influence of allergens that go and as you inhale them, they stimulate the Th cells into differentiation, and eventually, as they differentiate, then Th2 cells start releasing quite a lot of mediators into the bloodstream. These ones will activate the B cells and therefore promoting the formation of Ig antibodies that later on will perpetuate this type of reaction. As you can see on this image below, here the allergen is exposed. These small Y-shaped images are the IgEs that are connected on the outside of the mast cell. And as the allergen connects to the IgE, you can see all these small bubbles going around, which is the process of degranulation that happens on the mast cell with a massive release of quite a humongous number of mediators. Also, due to the connection with the plasmocytes, then there's further IgE production that then increases the capillary permeability, leading to the edema with the symptoms that we talked about before. As you know, most of the symptoms that you see on allergic rhinitis are inflammation mediated and edema mediated. So another good image for you to see what is happening is this one. So as you can see, the serous secretions from the cells there starting increasing significantly, going into the surface, and this leads not only to that clear liquid that we're talking about that comes out when we have itchy nose or even itchy eyes, but also underlying it you're going to see all the edema. Again, every time that there's another exposure to the same allergens, this is going to lead to further inflammation process, but also you can see there that then eosinophils start being aggregated on the mucosa, and this often leads to a change in the pattern of the cell of the mucosa itself, leading to chronic changes. Later on, I'm going to also show you how this eventually is what is going to lead to the development of allergic asthma. So in this one, you can see clearly that when this inflammation settles, there's several parts of our body that are going to be affected. And I'm talking about parts of our body related to the nose, naturally. So as you can see here, the nasopharynx, normally people, if they complain about an itchy throat or tickly cough, it's because of that. But also you can see that sinusitis can derive from this. as the opening for the sinuses will going to be closed, and they normally are below the turbinates. Also, you can see that it will affect the sense of smell, because the inflammation itself will also cover the olfactory region, so therefore preventing someone to smell as normal as possible. But also there's a connection that you can see there with the auditory tube. And this means that the normal aeration of the middle and inner ear is not as effective as possible, leading often to problems which can cause eventually a middle ear infection. So this leads to the main signs and symptoms, as you can see there, because it does not just affect the nose, though it's called rhinitis. It also can affect the eyes, can cause headaches sometimes because of sinusitis, also because of problems with vision, also can cause an itchy or sore throat, postnasal drip syndrome, and all of this associated will cause a cough. So how about will we make a diagnosis? So the main important thing to note is that we need to have a proper allergy history. So we need to see if in the family there's an history of asthma, eczema, rhinitis. Are there any food allergies, both on the child or in the family? Is there a medication allergy? What else family history-wise that is important for us to note? Because sometimes people don't even realize that they have symptoms of allergic rhinitis and they have been lingering for years, and they just treated with normal antihistamines. So also very importantly is examination-wise. One of the pathognomonic signs of allergic rhinitis is the presence of a nasal crease. Normally it is transverse because of what is called the morning salute. So the children tend to itch their nose by putting the palm against their nose and pushing it upwards. But also sometimes you see people scratching their nose side to side. So I've seen quite a few patients in which they, instead of having a transverse nasal crease, what they're going to have is like two diagonal small nasal creases, making almost a kind of an inverted V shape. The other thing is to look into the nasal mucosa, and that you can do it with a normal otoscope. And the normal nasal mucosa tends to be pink in nature. If it is bluish or pale, this is a sign of allergic rhinitis. If it is red, then we think about more of an inflammatory, infectious type of rhinitis, but also look into the type of discharge. If it is clear discharge, again, points towards being rhinitis, allergic rhinitis. If it is dark, if it is green, if it is kind of yellowish, so kind of a purulent discharge, we're talking about an infectious type. Septal deviation. It's also important to note that sometimes people have a blocked nose, mainly because there's a septal deviation and there's nothing else going on. But also, interestingly, you need to look into the eyes, the ears. As I said before, sometimes you can have signs of dull eardrums, which presents as being middle ear infection, so otitis media. But look also into the throat, chest, and skin, because you need to see other signs of atopy. So what do we normally do investigation-wise? So I referred before, skin prick tests. Skin prick tests is very good because you have a positive and a negative control. They are very allergen specific. You can repeat the tests and they normally tend to come with more or less the same result with a minimal variation in millimeters. And they are highly accurate. It takes also 15 minutes. So children come to my clinic, I do the test, and 15 minutes later, I can tell them if they are allergic to a certain airborne allergen or not. And we normally tend to measure the wheal and not the flare. And this is an important thing because sometimes people are afraid that the redness is so big that means a massive allergic reaction. It's not. It's just a flare. Blood tests. We do specific IgE sometimes if there's a very positive history, but the skin prick tests are negative, but we never do panels. Please don't do it. So what tend to be people allergic to? So common: pollens, house dust mites, pets, and molds. There's also can be cockroaches and rodents, though this is less frequent, especially in the UK. Cockroaches tend to be more frequent in countries like the United States, and rodents tend to be more frequent either in rural areas or very old houses. So for you to have an idea about the pollen season, everyone has a different pollen season if they have different things that they are allergic to. So what you see is that the blossoming of trees or even certain types of weeds vary significantly throughout the year. And looking at those and when people have symptoms can guide us to have an idea of what in reality is causing their allergic rhinitis. So after we have all that and after we have all the investigations, we need to classify it to see how bad it is. So ARIA, so the allergic rhinitis and the impact on asthma, have come with this very nice slide that can tell you exactly how things are. And you can see a mix of all of them between intermediate mild, intermediate moderate severe, persistent mild, and persistent moderate severe. And this, according to the symptoms that you see there, and if you match those symptoms, it tends to be fairly easy for you to classify rhinitis according to subtypes and therefore decide on what treatment do you need for the child in front of you. So again, according to ARIA, there's a stepped way to treat symptoms according to the type of the symptoms that the child is presenting with. So with mild intermittent, normally start by the most important thing. We give information leaflets about what allergens are they allergic to and how to do as best irritant avoidance as possible. And sometimes you see significant improvements. Also, we can go for oral antihistamines or sometimes local, and this is nasal sprays, depending on the age of the child. If it is starting to go a little bit worse than that, on top of the measures that you already have, it would be a good idea to start an intranasal steroid. Of course, with the other steps, we put all this, but when it comes to the mild persistent, and you see that there's already a significant impact on life, then it is the time that you need to start thinking about immunotherapy. So, and treatments-wise, and probably going to ask me what medication do I normally use in clinic. So, according to the age, this is what normally tends to be used. Mometasone furoate tends to be a very effective nasal spray and a very effective steroid to treat the signs of both allergic and non-allergic rhinitis. When I spoke about before about antihistamines, local antihistamines, azelastine hydrochloride tend to work quite well. Also, you can use sodium chromoglycate drops, not just for the eyes, but for the nose. But on a child sometimes can be a bit tricky to apply the drops. But if you manage to put them lying down and do a couple of drops on the noses, it can also happen, or it can also help. Antihistamines wise, go for second generation. Don't go for first generation, because unless if you want to use a side effect of first generation antihistamines that can dry the nasal secretions, then second generation antihistamines are better. So, as you can see, the hay fever medication, apart from something that is beclometasone that we tend not to use, the other ones tend to be quite important to use. But one important thing is, do not, and I'll go back to the previous slide, do not use a steroid that is a propionate. A furoate works for 24 hours and has a less systemic absorption than the propionate. So please avoid that one as best as possible. So, importantly, technique. Very often people don't know exactly how to do it, but it is important that whoever does it has the head down or put the child on a head down and forward position. Not always 2 sprays on each nostril, sometimes 1 spray is enough, but don't sniff too hard, or a lot of the medication that you're spraying into your nose will bypass your nose and probably end up in your lungs. Also, very important to use like a cross of hands with the left nostril, with the left hand to your right nostril and the right hand to your left nostril. Finally, we're talking about immunotherapy. Currently, there's several forms of immunotherapy. The most common ones being it sublingual or subcutaneous to pollens, house dust mites, and also you can use it to treat in pollens wise between tree pollens and grass pollens. There's also immunotherapy for pets, which is often used. And this basically is the use of a regular low dose of the allergen that the child is allergic to, and tends to last, the treatment tends to last for about 3 years, and it is highly effective because often as you stop the immunotherapy after 3 years, the effect is long lasting for about 2, 3, sometimes more decades. So just a brief touch now into one thing called other symptoms that can come associated with it. One of them is the oral allergy syndrome, in which people normally, this is fruits or vegetables, normally they have like a tingling sensation to lips or tongue, sometimes a tickly throat as well. Normally, if they eat those fruits or vegetables in a cooked form, the symptoms tend to disappear. Other comorbidities, as spoken before, conjunctivitis, and this is called the typical allergic conjunctivitis, sinusitis, polyps developing on the nose if this is not appropriately treated, and for this ENT would be very important to be involved because they would need to be removed. Otitis, as again we spoke about before, and bronchial asthma. So not only that, but it can cause flare-ups of eczema. Normally a lot of them people are denied from saying that they can cause, but actually it does cause flare-ups of eczema. And of course, as you see there on the right side, you have the typical atopic triad between the atopic asthma, dermatitis, and allergic rhinitis. So looking into that one, and especially looking into the atopic asthma, let's look into something that came out in the ARIA guidelines. And one of the recommendations that they do is that any patient with persistent rhinitis should be investigated for asthma. But at the same time, any patient with persistent asthma should be investigated for rhinitis. And as you see there, you can see that the mucus production and the eosinophilic infiltration throughout the airways will progress into the lungs, causing the signs that we talked about previously. So what is the association between rhinitis and asthma? There are several studies that show that allergic rhinitis is very common in those diagnosed with allergic asthma and the other way around. And uncontrolled rhinitis can also lead to more severe asthma, can also lead to exacerbations or symptoms of asthma during the spring and summer when we don't have appropriate treatment on the first point of entrance of the allergen, which is the nose. So this happens when the inflammatory chemicals such as histamine and leukotrienes travel to the lungs, either because of the postnasal drip syndrome or bloodstream-wise. Therefore, this makes the inflammation worse than what it was and makes the airways being more sensitive and reactive to the asthma triggers. Many of these chemicals will recruit other chemicals in cells like mainly eosinophils and cause eosinophilic infiltration, and this will enhance the inflammatory response. Also, the eosinophilic infiltration will cause chronic changes to the airways, which lead into persistence of symptoms, and as you see there, the persistence of rhinitis and asthma symptoms. Again, the link between asthma and rhinitis is been increasingly proved over the last few decades, and due to so many investigations that have been made, mainly with sequential biopsies from the nose up to the lungs to prove that this eosinophilic infiltration and march was there. Another explanation is that people who have rhinitis have asthma because there's not a lot of flow through the nose. The nose is blocked. And because the nose is blocked, the people tend to prefer to breathe through their mouths. So what does this lead into? As you know, the nose will cause humidification of the air and therefore maintain the mucosa quite moist. By breathing through your mouth, that leads to the mucosa on the airways to be quite dry, and therefore also is not as heated as it should be when you breathe through your nose. So when the cold air reaches the bronchial tubes, As a side effect, they contract, and this flow is identified as harmful, and therefore also starts a cascade with inflammatory processes as well. So, as we spoke about before, I was discussing about the allergic march, and the allergic march is basically going from eczema to food allergy, rhinitis, and asthma. And this is the variation on the airways that happen throughout the time, and normally starts when the children are about 1 to 3 years of age. So as you can see there, then it can develop throughout age, and you see in both of the slides that allergic asthma tends to develop from about 5 years of age onwards. So the bronchial asthma itself is the inflammation of the bronchial mucosa with hyperreactivity of the bronchi. This means that, again, the airways close abruptly to prevent the normal flow of the air beyond the inflammatory process. So how do we classify asthma, or actually the probability of asthma? This is a very busy slide. I'm not going to go through all of that. This is shown on the BTS guidelines and show what increases and decreases the probability of asthma, but also if there's an intermediate probability. How do we assess and how do we treat? Again, there's a very nice flow chart on the BTS guidelines and show with a high probability what type of treatment do you use, and I'll show you soon the stepwise approach for people with asthma. But this is the flow chart that we tend to go through. So we have a stepwise approach from 5 to 11 years of age that starts with slow-acting beta agonists, so basically salbutamol, and we start escalating all the way until step 6. There's not a lot of variation between the stepwise for 5 to 11 and from 12 plus, with some of the things that we use mainly to steps 5 or 6 that need to be considered as an alternative treatment, being something that we use on ages 12 or plus. Importantly, again, as with technique, is what do we use? As you can see here, this spacer is more used to carry with patients or with parents all the time, but we tend to use this one, the volumetric spacer, especially used at home or even in hospital. And this gives you a better idea or a better exposure to the medication, being a steroid or salbutamol that we're giving to the child. So I discussed before about the cost of allergy. For you to have an idea, asthma constitutes about 1% of global disease with over 15 million lost disability-adjusted life years. So the cost of asthma exceeds that of HIV and TB, and the direct costs in the NHS that was supposed to be 130 million. I'll show you soon that actually is not. It's far more than that. And as I show you below, the indirect cost is 100-fold higher. So, for you to have an idea, the direct and non-direct costs to the NHS per year, and this is a study from 2004, make notice, is 1.03 billion pounds per year. So basically, if you treat the nose as soon as possible, you can prevent a lot of these costs from being there. So bear in mind that 39% of children that have a diagnosed allergic rhinitis, a diagnosed allergic disease, will have either asthma plus or minus eczema, plus or minus rhinitis, and plus or minus other allergic conditions, namely food allergies. 38% of children have had symptoms in the last year, so quite a significant one, and very often some of these ones are the ones that are on daily doses of antihistamines and never have been tried on a simple nasal steroid, like I spoke about before, mometasone furoate. About 11% of children will have more than one disorder, the ones that I spoke about above, so asthma, eczema, rhinitis, food allergies. Excuse me. It leads to, and again, for studies in 2004, to 12.5 million GP visits per year, and I guess that probably you would like to decrease all of that. So basically, this is the reason why we should look into treating the nose as soon as possible and preventing it from moving forward into the lungs. So Hopefully I didn't rush too much into the slides because I had too much to say. I thank you for listening to me, and I hope you enjoyed it.